All right, it's 4 o'clock-ish. Thank you for coming. We recognize you had strong alternatives. It's Saturday, it's 4 o'clock. The River Walk is just, I actually don't know where it is. I think it's over there. Anyway, thank you for coming. This is really a session for those of us who practice clinical anesthesiology. You're looking at a patient, you're looking at a chart, you flip over to the labs, you see some concerning things, and you want to know what to do. Can we do the case? Can we not do the case? If we do the case, what do we need to do? If we're not going to do the case, what do we need to do? And so we're going to talk about a variety of different lab permutations and perturbations that we see every day in our practice through the lens of those of us who practice critical care. This is a snap talk, and so we have 5 speakers in about an hour, so that means each of us get about 10 minutes. I'm going to just introduce everybody very quickly, but y'all will meet Drs. Jarzabowski, Gupta, Cotter, and Kuza, not necessarily in that order. And I'm going to start us off. My name's Craig, and it's nice to meet everybody. I'm going to be talking about sodium, just FYI. I'm not a nephrologist. I do have to disclose that up front, but I'll do my best. The overall session learning objectives are here. We only have 10 minutes each, and so I'm not going to read them to you. Okay, so let's talk a little bit about hyponatremia. Actually, the idea for this talk came from when I was working in GI, and I got a call from our nurse who runs the board, and she said, Craig, the next patient has a sodium of 130. Would you like me to cancel the case? And I said, oh, goodness, no. Why would we do that? And she said, oh, well, your colleague who was here yesterday cancels everyone who has a sodium of 135 or less. And I said, oh, that's interesting. And so what I want y'all to know first about hyponatremia is that it has been very convincingly associated with poor outcomes in a variety of different disease states. We'll talk more about why that is in a minute, including one that we care a lot about, which is heart failure, and we'll come back to that in a minute. When you look at the association between the patient's serum sodium when they hit the doors of the hospital and how likely they are to live or die, expressed in scientific terms, that's the association between hyponatremia and in-hospital mortality. What you see is there's a bimodal relationship with the risk of in-hospital mortality over here on the y-axis, the patient's admission serum sodium down here on the x-axis. And what you'll see is that when the sodium is very low, the patient is more likely to die as opposed to when the sodium's like 140. And likewise on the other end, just real quick, when the sodium's very high, which we're not going to talk about, risk of mortality is also increased. This is the same in kind of a perioperative sense. And when we look at the odds ratio for things like any perioperative complication, we see that there's about 37% increased odds of perioperative morbidity in patients who come in hyponatremic. And likewise, there's a 27% increased odds of increased periop mortality in patients who come in hyponatremic. And so what I want y'all to know about sodium, I recognize it may not be your favorite electrolyte, but it's been convincingly associated with poor perioperative and outcomes in hospitalized patients. Okay, so why is that? The first thing we need to remember is that we measure serum sodium as a concentration. And so, with that in mind, the patient's total body water could be high, low, normal. The patient's total body sodium could be high, low, normal. What we care the most about, though, is probably the patient's total body water, right? Like 9 times out of 10, hyponatremia is going to be due to fluid retention, not necessarily problems with total body sodium. I say often because there are exceptions to this. I probably should have put like some nachos here or something. But, obviously if someone has very high dietary solute intake, that can be a different story. One thing I learned in the previous session is that these laptops, if you move your hand, they'll advance the slides, which is interesting. So I have to try to keep my right hand down here. Okay, so let's say, again, you're seeing a patient in front of you, you've got the chart open, the sodium is low. The first thing you want to try to do is figure out why in the world is the sodium low. So there are some oddities, right? There are some things, and if this was a critical care lecture, if y'all were critical care fellows, I would talk about it for a long time. But here, what I want y'all to know is that in a perioperative context, we don't really see these things, right? Like, this is like hyponatremia without hypotonicity. We just don't see it all that much. You'll know it if you see it. So we're going to skip past that, okay? The first thing that you want to do is that you want to know if the patient has hypotonic hyponatremia. And this is something that you can do clinically, right? Like a lot of these patients will have perturbations of their volume status. Also, typically with your laboratory studies, you might have a plasma osm, either calculated or measured, that comes back. That's relatively easy to rule in hypotonic hyponatremia if you see it. The second thing you want to do, if it turns out that the plasma osmolarity is fine, or maybe even the plasma osmolarity is high, is you want to say what's going on with the kidneys, right? If the patient's got crummy kidneys, that's very likely that they're retaining some fluid. Also, if the patient's on thiazides, right, this can deplete total body sodium. It can drive hyponatremia. Once you've done those two things, the next thing that you could do is just get a sense for the patient's volume status. So again, 9 times out of 10, hyponatremia is due to increased total body water. That's really easy to sort out, right? The patient's going to have peripheral edema, they're going to have pulmonary edema, right? You can rule this out with your hands, with your stethoscope, with diagnostic testing, with point of care ultrasound. We have a lot of different ways to do this. Anyway, so keep all of those things in mind. I think it's just a very pragmatic approach. When you see, you're in the chart, right? Sodium is low. What other labs are you going to be looking at in the chart? What are you going to look like? What are you going to look at when you get to the patient's bedside? So that brings us to the next thing. Okay, so we know the patient's hyponatremic. We have a sense for what the etiology is. You'll remember, Craig told me 9 times out of 10 the patient's got too much total body water. So then the question becomes, when should we treat it, right? Like, when do we need to do something about it, either during the case, before the case? There are a few different things that you can look at, specifically 3 I'm going to talk about, that should influence your thinking about when to treat hyponatremia. The first is the chronicity of the problem. So a lot of patients, especially with heart failure, right, they tend to hang on to a lot of total body water, no matter how well diuresed they are, right? They're chronically hyponatremic. The brain has been adapted to this. And a lot of times, chronic hyponatremia is less concerning, right? We may not need to do very much for those patients. If you're ever in the chart and you see that someone's serum sodium has dropped precipitously within the last 48 hours, right, within the last 2 days, that's acute hyponatremia. That's often concerning, right? Like, one of the things that we worry about in these patients, right, is cerebral edema. And so that would be maybe the first thing that you want to tease out. How quickly has the sodium dropped? If it's very quickly, the chances that either A, the patient's symptomatic, or B, we need to treat it are higher. Okay. The second thing, I alluded to this already, is the patient's symptomatology. So if you got a chronically hyponatremic patient, they're totally asymptomatic, the likelihood that you need to do anything about it is very low. On the other hand, you have a patient whose sodium has fallen acutely, right? They've developed maybe some confusion, alteration in mental status, other clinical signs, maybe of increased ICP. Maybe you see that they're a little bit cold, right? Suggesting they're holding on to fluid. Maybe the heart is struggling with that, right? That would be problematic. That suggests that maybe we need to do something about the hyponatremia. The third thing, and this is maybe the weakest of the 3 heuristics, is how low the sodium is. So generally speaking, sodium of 130 or greater, we typically don't need to do anything about it. Typically, those patients are not going to be symptomatic, whereas patients with a serum sodium of less than 120 almost universally are going to be symptomatic from that, even if it's chronic. And so in those patients, we may need to think about doing something about it. Again, the symptomatology is, I guess, what I want to focus on for y'all. Obviously, no matter if it's acute or chronic or what the absolute value is, if you see a patient who's got a low serum sodium and they're not mentating well, and you're worried about increased ICP, in particular, that would be a thing that we need to focus on. But anyway, so key concept number 2 for y'all, when we're thinking about whether or not to treat, right, we're looking at how quickly has this hyponatremia developed? Is the patient symptomatic or asymptomatic? And the absolute value, got to integrate all of these 3 things, okay? And so again, in an ideal world, we would treat the hyponatremia by correcting the underlying problem. Like, if the patient's got heart failure, right, like they need a bunch of diuretics. If they're on thiazides, for example, then they haven't had access to solutes or free water, like, we need to fix that problem. But I gave you a very long differential earlier for all of the things that can make the sodium lower. And you're probably thinking to yourself, like, this is kind of complicated, and it's going to take a while, and it's kind of confusing. And you would be right about that. Like, you would be 100% correct about all of those 3 things. And so from a practical standpoint, if we have one of these patients, right, who fits into one of these 3 categories that I talked about, and we need to treat them pharmacologically, right, the main thing that we worry about, as y'all probably all know, in correcting hyponatremia is this hypothetical risk for osmotic demyelination syndrome, which is rare, very rare, but bad when it happens. And so when you've got a patient who's hyponatremic, you're thinking about treating them, just keep in mind what their risk factors for this might be. And in particular, patients who are starting out at a really, really low sodium, patients who have other electrolyte permutations or disturbances, I should say, and who have some specific causes of hyponatremia are probably at higher risk. The bottom line, though, for these patients with osmotic demyelination syndrome is we're going to give them some hypertonic saline, and we're going to give them a little squirt of desmopressin to help reduce the risk of the serum sodium overcorrecting. For patients who are at low risk for osmotic demyelination syndrome, guess what we're going to do? The exact same thing. We're going to give them some hypertonic saline. 3% sodium chloride, 15 to 30 mLs an hour. Check the labs frequently, see what happens with the sodium. If you're an inpatient anesthesiologist, not treating inpatients, but impatient, like not very patient, like most every anesthesiologist, myself included, a little 3% sodium chloride bolus, 100 mLs, repeat that once or twice if you want, check the serum sodium, you're going to be good to go, okay? That is shared across both the high risk and the low risk approach. Remember, patients at high risk for osmotic demyelination syndrome, a little bit of desmopressin in there helps reduce the risk of overcorrection. The goal, the book goal, right, is to raise the serum sodium by no more than 4 to 6 over a 24-hour period. There's actually a pretty robust body of literature challenging this, saying that we may actually be able to correct the serum sodium a little bit faster, maybe even up to 10 milliequivalents in a 24-hour period. It may even be better for patients. Again, the book answer today, like on the boards, on the witness stand, is 4 to 6, but just know that if the serum sodium does correct a little bit faster, it's not necessarily dangerous for the patient and may actually be better for them. And so I guess the third key concept I want you all to remember is that we're going to stratify our treatment approach to the patient based on the risk for osmotic demyelination syndrome. Okay, those are my 3 key take-home points for y'all. You're all now all experts in hyponatremia. If you find yourself with a lot of self-loathing and you want to talk more about serum sodium, this QR code will give you my email address. Feel free to drop me a line. And with that, I'll thank everybody for your attention. Okay.
All right. Hi, everyone. I'm Mary. I am an anesthesiologist. I'm an intensivist, and I have no financial disclosures, but I do have to confess a secret love of acid-base disorders, and I spend way too long talking about them, as I think most intensivists do. There is actually a simultaneous talk going on right now somewhere in this building about Henderson-Hasselbalch versus Stewart approach to acid base, and this is not that talk. So if that's what you were looking for, we are not going to do that. But for this setting, what I was looking for were clinical scenarios that are significant, potentially modifiable in the perioperative period with a proven benefit or a change in patient outcome based on those modifications. And through that lens, I came up with 2 clinical scenarios where perturbations of bicarb fit those criteria. So the first I want to talk about is using serum bicarb to predict severe OSA. And the second is using or recognizing metabolic acidosis, specifically in the setting of euglycemic DKA, which is one of our newer and possibly more increasingly common perioperative scenario. So in the interest of time, I won't go into great detail, but this whole talk was spurred on by a case I had with an outpatient hip arthroplasty on an obese female who came in with a bicarb of 29. So our pre-op clinic had screened her. She had OSA, and she said she was using her CPAP. And I saw that chemistry panel, and I thought, maybe not. So what do you do when you see the serum bicarbonate that's elevated? So it can be a primary metabolic alkalosis, particularly with diuretic use, although chronically that is less common. Also, you think about GI losses with your patients who have gastric outlet obstructions. Those are sick patients. You're going to see that. That's going to be a very different looking patient than someone who is well and coming for elective surgery with a high bicarb. But more likely, you're going to see someone who really has a primary respiratory acidosis, and that bicarb is their metabolic compensation for that. And so that's usually the OSA population or obesity hypoventilation, or your severe COPD patients will do this as well. And we'll talk about OSA in this setting in particular. So the mechanism of this hypercapnia, just to review some physiology, I don't know if you can see my mouse. No, that top curve is your tidal volume ventilation. So awake, you see a nice airflow happening. The patient falls asleep. They have hypopneic episodes where their CO2 then begins to accumulate in the serum. So that's the bottom curve there. They then wake themselves up. They compensate by actually having a greater minute ventilation while they're kind of compensating for that CO2 accumulation, and they eliminate it. And at the start, or mild sleep apnea, that will compensate, and their acid base will remain relatively normal. But as that disease progresses, as their apneas progress, they're unable to compensate for that CO2 that's accumulated, and that's when you're going to start to see the bicarb climb as their kidneys respond over time. The slope of that curve between the CO2 and the bicarb correlation is higher with chronic respiratory acidosis. The kidneys have more time to respond, so they do. So with our patient with a bicarb of 29, roughly that would correlate to a PaCO2 of around 50 that person lives at chronically. Okay, so why does it matter? And how can we use it? So you might be familiar with Stop Bang Score. A lot of places use this to screen out patients ahead of elective surgery, to identify those who might be at high risk for OSA, test them, treat them better for perioperative outcomes. So the Stop Bang Score has a great sensitivity. It's a good screening tool, but it has a low specificity. But if you add serum bicarb to that, you actually get a huge increase in the specificity, specifically for severe sleep apnea patients. So this study done by Dr. Chung and Associates did just that and found that if you use a cutoff of 28 for your bicarb, your specificity of diagnosing severe OSA will go from 28% to 80%. And that if you use 30 as a cutoff, that goes all the way up to 96%. So all of a sudden you have a pretty powerful tool to use for identifying these high-risk patients. Okay, so we can identify potentially high-risk severe OSA patients. So what happens to these patients around the time of surgery? Well, the same group looked at patients who did not know they had sleep apnea. They enrolled all sorts of mixed surgical population that you can see there. They did a polysomnogram pre-op and blinded everyone to the results. So these patients were not known to have sleep apnea. And then they went through standard of care as they would for perioperative, their whole perioperative course. So if they were going to be admitted, they were. If a clinician thought they needed oxygen, they were given oxygen. If they needed positive pressure therapy, BiPAP or CPAP, they were then excluded from the trial. But they actually kept data on them for 7 postoperative nights. And this is where the data comes from that shows the AHI score worsens every night, peaking at post-op night 3. So your patients will have worse apneic and hypopneic episodes all the way until post-op night 3, and significantly more so with the group who had severe OSA than the group that did not have OSA. And that correlates with their oxygenation as well. So these patients had lower sats and spent more time with significantly hypoxemic episodes. Okay, so you've got a lab test that predicts severe OSA. We know severe OSA is associated with hypoxemic events. So what does that mean for perioperative outcomes? Well, the largest study we have to date followed 1,200 patients without known OSA, and they did the same thing, blinded them perioperatively to their status and gave them pulse oximetry, again, blinded to the patient and the clinicians where appropriate. So if they were inpatient and needed that monitoring, they received it. And then they followed them for a composite outcome of myocardial injury after non-cardiac surgery, death, heart failure, venous thromboembolism, AFib, stroke, and all within 30 days. And what they found was the patients who had undiagnosed severe OSA that was untreated were significantly more likely to have the composite outcome. And significantly, the significance was only with the patients who had severe OSA. Moderate and mild did not. Interestingly, for my world, these patients were the ones who were more likely to be admitted or readmitted to the ICU and require postoperative intubation or non-invasive positive pressure ventilation. So what do we do with these patients? We do have consensus guidelines on managing them perioperatively. They are a decade old. We are expecting updates soon. They emphasize trying to use neuraxial and regional anesthesia where possible, fully reversing neuromuscular blockade when needed, and using judicious opioids for trying to minimize respiratory depression. And spoiler alert, my patient did have very undertreated sleep apnea, was not using her CPAP, didn't like it, needed it in PACU, and ended up staying overnight unplanned for CPAP. So perhaps could have been avoided if we had incorporated bicarb and screened her out for more testing preoperatively. Shifting now to metabolic acidosis, I think the first thing to say is, the bicarb level on pre-op labs, if it's less than 22, you should really think about why your patient has a primary metabolic acidosis. And we could go into characterizing anion gaps and non-anion gaps, but essentially, if your patient has a metabolic acidosis, it's really imperative for you to understand what they're doing to compensate for it from a respiratory standpoint before you impair that respiratory drive with your anesthesia. And that can really impact what you decide to do. For a patient with a bicarb of 17, for example, if their pH, if this is an acute setting and their pH is 7.2, you might think very differently about running a propofol infusion and causing more hypoventilation versus trying to control their ventilation if you understand fully that acid-base situation. So serum bicarb correlates very well with base deficit. If you're someone who thinks in base deficit terms, this has been well validated. So if you see a serum bicarb of 18, that roughly correlates to a base deficit of 5, and also predicts a patient's ICU length of stay and mortality. And quickly to brush on euglycemic diabetic ketoacidosis. This is associated with our SGLT2 inhibitors. So this is a acidosis you may see intraoperatively, particularly if your patients were unable to stop these medications. So we have recommendations now that these patients should stop their medication, these are the Flozins, 3 to 4 days before coming for elective surgery. Some patients don't get that memo and they have their acute event and haven't stopped it. And so those are the ones who are going to be most high risk for having this DKA intraop. You're obviously not going to pick it up on finger stick because, as it says, they are euglycemic. Their clinical symptoms are very vague, and it can absolutely happen in the OR as you start to recognize an acidosis based on lab values. SGLT2 inhibitors are now seen way outside just type 2 diabetes management. We're seeing benefit in outcomes for cardiovascular disease, heart failure, CKD. More and more patients are on these drugs, and they will be coming to your ORs. So what are you looking for? Anyone with a bicarb of less than 18, you should suspect has a severe acidosis. They will have an anion gap metabolic acidosis if it is euglycemic DKA. My brain always goes right to the lactate. I'm an intensivist, and you'll see a normal lactate and probably normal renal function. That's kind of how this typically appears, and that's where you're going to think to measure your serum ketones. If those are positive, you basically have your diagnosis. And the treatment is very similar to the treatment of other DKAs. I assume you all have institutional protocols for this, but you're going to need fluids to restore intravascular volume. You're going to need close electrolyte monitoring, insulin and dextrose infusions to control this until it resolves. And then recommend endocrine consults for appropriate post-op management as well. So in summary, suspect a severe OSA case if you see a bicarb greater than 28 and triage that appropriately. If you have bicarbonate less than 18, you should probably investigate that acidosis before you impair that patient's ventilatory drive. And if you have unexplained intra-op anion gap metabolic acidosis, think about euglycemic DKA as a possibility if you know your patient's been taking one of our Flozin drugs. Thank you.
Hello, everyone. Thanks for having me, and thanks for being here with us on this lovely Saturday afternoon. I'll be talking about glucose today. As a side note, I will not be discussing SGLT2 two or one, because that's a whole talk in and of itself. So this is just going to be the very basics. I have no financial disclosures. Okay. All right, let me arrow over. Oh, come on. Okay, no financial disclosures. So basics. Should we be testing blood glucose in everybody? Short answer is no. So who should be getting it preoperatively? So anybody with known diabetes, pre-diabetes, or morbid obesity. You can consider checking it in patients undergoing emergent or urgent surgery, patients above the age of 45, anybody on chronic steroids or perioperative steroid administration, BMI of above 30, and then known risk factors for diabetes. So what is an abnormal glucose? So above 140 is typically defined as hyperglycemia. This can present either in patients either with undiagnosed diabetes, known diabetes, or stress hyperglycemia. The thing that kind of helps differentiate between the two is a HbA1c, so above 6.5, you think more diabetes. Hypoglycemia is a sugar less than 70. So we'll talk about hyperglycemia to begin with. What are the recommendations over labs? So ideally, anybody with known diabetes should have an HbA1c measured within 3 months of their scheduled procedure. Target HbA1c is less than 8%. So the HbA1c shouldn't necessarily guide whether or not you're going to cancel the case. It should be more the glucose that's driving that. However, if you have some time and your HbA1c is above 8%, you may want to optimize the patient prior to surgery. So what happens with hyperglycemia? What are the negative effects? So kind of the biggest thing in the literature is decreased wound healing, increase in surgical site infections, infections in general. These patients are at increased risk of perioperative cardiac events. And with that, you have increased mortality, worsened outcomes, increased length of stay. So what should we target our glucose? Normal fasting blood glucose is between 60 and 100. We have two society guideline recommendations for the perioperative setting. So the Society of Ambulatory Anesthesiologists and the American Diabetes Association. SAMBA recommends between 180 and 250, while ADA recommends 100 to 180. There have been studies that looked at stricter glucose control with a target of 80 to 140, and what they showed was that there was no improvement in outcomes, and there's actually increased risk of hypoglycemia. So a little bit higher is recommended. When should we be canceling surgery? So there's not great literature. This is ultimately the provider's decision. But typically elective cases greater than 250 or greater than 300. Again, this depends on your patient population. I work at a city hospital where a large majority of our patients, their glucose is not well controlled, and so we're just going to keep canceling them. So you kind of have to use your discretion, whether if it's a minor procedure, maybe we can sneak them by, but ideally you want them to be controlled. And then anybody undergoing emergent procedures, you need to proceed regardless of the glucose if it's a life or death situation. Now what about insulin pumps? So there's always a risk of pump failure, adverse events with this. These situations is if they're exposed to ionizing radiation, EMG fields, or electrocautery use. So the recommendations are if it's a short case, usually less than 2 hours in duration, you can have access to the pump. It's outside the surgical field. You can continue to use it while checking glucose intraoperatively. So either at their basal rate or you can decrease it by 20% and then just screen your glucose hourly. So intraoperative management of hyperglycemia, kind of the big takeaway points is don't be pushing IV insulin. So what's recommended is either sub-Q insulin dosing or IV insulin infusion. I'll just quickly speak on a case. We had a trauma patient with a sugar of 240, which is not abnormal for a trauma patient, but they were treated with 15 units of insulin IV push and ended up with a sugar of 30. So it's really ill-advised, and with a sugar of 240, I probably wouldn't have treated it in a trauma patient's stress response. But kind of emergent surgeries, anybody that's critically ill, poorly controlled at home, long surgical duration, or surgeries with large fluid shifts, you want to consider an IV insulin infusion. So you would treat above a sugar of 180. And then each institution should have their own different dosing algorithm. And if you're having an elective surgery and they don't meet these criteria, then sub-Q insulin is appropriate. So this is just a sample of a sub-Q insulin sliding scale. It's dosed based on the sugar level. And then there's two different dosages here. So you have patients who are insulin sensitive or naive. So this is elderly patients, somebody who is not treated with insulin or untreated, and then poor kidney function. And on the opposite spectrum for a little bit higher dosing is patients who are insulin resistant. So patients with home insulin doses of greater than 80 units a day. Anybody with perioperative steroid administration will get a little bit higher glucose dosage. And then again, this is a sample of a insulin infusion algorithm. So you're titrating based on your blood glucose checks. So either a increase or decrease in blood glucose level of 30, you're going to titrate, either increase or decrease your infusion. I'll briefly talk about DKA and hyperglycemic hyperosmolar non-ketotic syndrome. So this should be suspected in anybody with a blood sugar over 250. Be sure to check serum and urine ketones. Check at ABG, BMP. With DKA, you'll have an anion gap, and it should be suspected in anybody with an infection, sepsis, emergent surgery, poorly controlled diabetes. So if you discover this preoperatively, you would cancel the case, admit the patient to the ICU, and consult endocrinology. If this is something that develops either intraoperatively or the patient is presenting with DKA and needs a life-saving surgery, you would kind of have to simultaneously treat intraoperatively with an insulin infusion, fluid infusion, and frequent lab draws, and ideally try to get them to get the surgery done as soon as possible, and then ICU admission with endocrinology postoperatively. So hypoglycemia is, again, sugar less than 70. Some of the things associated with it are confusion, behavioral changes, seizures, tremors, diaphoresis, and most notably for us is delayed emergence. As with any extreme in labs, it's associated with increased length of stay, worse outcome, and increased mortality, so try to avoid it if possible. And management, so there's two different things you can do based on the values. So 50 to 79, you could give half amp of D50, or you can start a D5 half normal saline infusion at 100. Less than 50, you would give 1 amp of D50 or start D5 half normal at 100. And the important thing to note is that you are checking your blood glucose every 15 minutes until it reaches above 80. So you have to check a little bit more frequently. Once you've achieved a blood glucose of 80, you can check it, space out checks to 1 hour, and then continue treatment as necessary. And then this is just a summary of the SAMBA perioperative blood glucose management guidelines, just some highlights. So strong recommendation to delay surgery in anybody with signs and symptoms of DKA or HHNS. The prehydration that we have recommended in a lot of ERAS pathways recommends a carbohydrate solution that the patient drinks. So in known diabetics, just replace this with water instead of the carbohydrate drink. Again, emphasis on using sub-Q insulin to treat hyperglycemia, and if needed, IV insulin infusion. Use point-of-care glucose meters to confirm accuracy of continuous glucose monitors and automated insulin dosing systems pre-procedurally. And then a question I get a lot asked by residents is, can they get Decadron, diabetics? And the correct answer is yes, they can. Lower dosage is recommended. The 4 milligrams is fine in diabetics. And then all hospitals should have a blood glucose management protocol with how they treat hyperglycemia and hypoglycemia. These are my references, and thank you so much for your attention.
Okay, good afternoon. I'm Betsy Cotter. I'm excited to be here with you today to talk about a couple of proteins and peptides that we're all familiar with on some level or another, and that's cardiac biomarkers. So over the next 10 minutes or so, we'll be shifting the lens from their traditional use in the diagnosis of myocardial infarction and heart failure to how these molecules behave, inform, and sometimes mislead us in the perioperative arena. I probably don't need to tell this group that perioperative cardiac complications following non-cardiac surgery are both relatively common and can be serious. Out of some 50 million surgeries performed annually in the US, almost 1% of patients will die within 30 days. And if we framed that as a disease, it would rank as the third leading cause of death in the country. Perioperative MI accounts for a third of these perioperative deaths, and for those who survive their cardiac events, the story is only slightly better. They face longer hospital stays, increased medical costs, and reduced survival at both 30 days and 1 year. Historically, perioperative cardiac risk stratification relied heavily on the functional assessment and was used alongside tools like the Revised Cardiac Risk Index and the other scoring systems that are listed here. However, in contemporary practice, these models often fall short. They've performed only moderately well across broad groups undergoing non-cardiac surgery patients, and even less well in higher risk groups, such as those patients undergoing vascular surgery. Due to these limitations, there's a growing effort to improve these models by incorporating additional risk markers, such as calcium scores from cardiac CTs, and importantly, biomarkers. Enhancing pre-op risk stratification with biomarkers aims to clear the fog a little bit of the uncertainty that still surrounds the management of complex or high-risk patients. An ideal biomarker for clinical use should be widely available, precise, unaffected by unrelated factors, and provide diagnostic or prognostic value. Importantly, it should also lead to an actionable clinical pathway that improves outcomes. The quest to find the best biomarker is not a new one and really started back in the 1970s with AST and then CKMB. But in contemporary practice, two have emerged as the most relevant and useful. It's BNP and cardiac troponin. So we'll start off by discussing BNP, or B-natriuretic peptide, first. BNP is widely used in clinical practice to help identify cardiac origins of dyspnea, and has evolved to guide the management of heart failure through guideline-directed medical therapy. It's also by far the most studied biomarker for cardiac risk prediction. BNP is released from the cardiac myocytes in response to mechanical stretch. The circulating concentration of BNP reflects the magnitude of the volume or the pressure overload in the heart. BNP is first released as a prohormone. It's then cleaved into two parts, the active BNP and the inactive NT-proBNP. While both of those reflect the same underlying cardiac stress, the lab ranges differ, primarily due to the passive clearance and the longer half-life of the NT-proBNP. Because of this, NT-proBNP tends to have higher circulating levels and is thought to be more sensitive for the detection of heart failure. So why should we consider checking NT-proBNP before surgery? Well, we know that even a single preoperative elevation of NT-proBNP is associated with major adverse cardiac events after non-cardiac surgery, and our traditional risk assessment models only perform moderately well. So the key question is, can adding NT-proBNP to the risk scores actually help improve this risk stratification? The forest plot I provided here is from a Cochrane review and is just one example of some of the data that helps answer this question. And it compares the performance of risk models alone to risk models with biomarkers. So on this plot, each study has two lines, with the black line representing the RCRI alone, and the red line showing troponin, NT-proBNP, NT-proBNP plus troponin, and then troponin at the bottom. Across the board, the addition of the biomarkers increase the performance of the risk score. And in fact, NT-proBNP has even been shown to outperform echo in predicting major post-op cardiac events. So if we accept that NT-proBNP can be helpful, the next logical step is identifying the thresholds that indicate the elevated risk of myocardial infarction or death at 30 days. Several cutoffs have been proposed, but an NT-proBNP of less than 100 is associated with 1.7% incidence of MACE. At 100, it increases to 3%. At 200, it goes up to almost 8%. And at 1,500, the risk of MACE is 16%. So knowing all of that, most have settled around this less than 200 value as a cutoff for high risk. The next logical question then is, which patients are most likely to benefit from the preoperative measurement of NT-proBNP? And as of September 2024, the latest ACC-AHA guidelines recommend incorporating NT-proBNP in testing for certain high-risk patients. So for those patients that are undergoing elective, elevated risk, non-cardiac surgery, the guidelines suggest testing, those with known cardiac disease that are age 65 years or older, or are 45 years old with concerning symptoms. So then once you measure it, what do you do with that information? Thanks to the strong negative predictive value, a low NT-proBNP generally suggests that it's safe to proceed with surgery. However, when it's elevated by the cutoffs I just discussed, it should serve as a sign to pause and consider what underlying pathology might be contributing to this result. It's not necessarily a stop sign, but an invitation to take a closer look. This slide is adapted from the 2024 updated guidelines, and this first thick arrow here highlights the decision point where the addition of biomarkers is added to the pre-op assessment. And then here we zoom in on the branch point following cardiac biomarker testing. This is the point where if an NT-proBNP is positive, it suggests a pause and an opportunity to discuss the best path forward with a multidisciplinary team. In most cases, the next step is likely a transthoracic echo. This could also be an opportunity to incorporate focused cardiac ultrasound. It is important to note that no specific management pathway has yet been shown to improve outcomes in patients when it's elevated. So while we have the useful tools for risk identification, we're still working on what to do once that risk is recognized. Now, you probably also noticed that the troponin is included in this decision framework. As you'll see in a moment, if your patient meets the criteria to check a BNP, it's also reasonable to consider checking a pre-op troponin. It will provide a baseline value in case postoperative troponin monitoring becomes necessary. Additionally, in patients with elevated BNP, the trending of postoperative troponins may help capture subacute myocardial events that may otherwise go unnoticed. While it's intuitive that a large postoperative troponin elevation is concerning, what may be less obvious is that even modest elevations can be clinically relevant. Many of our postoperative patients may not experience or may not be able to report the onset of chest pain or other ischemic symptoms, whether that be due to sedation, cognitive impairment, or other perioperative factors. And as a result, they may not meet the criteria for a myocardial infarction. And that's where the concept of MINS comes in, or myocardial injury after non-cardiac surgery. MINS includes type 1 MI due to plaque rupture, type 2 MI due to supply-demand mismatch, and troponin elevations without overt MI, as long as the cause is presumed to be ischemic, meaning that non-ischemic causes like PE, sepsis, and stroke have been ruled out. And MINS is far from benign. It's associated with a 30-day mortality rate of about 10%. Even patients who never report ischemic symptoms have an elevated mortality rate. So stated differently, asymptomatic MINS still carries real prognostic weight. But interpreting troponin values in the postoperative setting may be tricky, as some patients have chronically elevated troponin levels, as in patients with renal dysfunction. And to diagnose MINS in those cases, we are trying to capture this acute rise and fall associated with new onset myocardial injury. For patients with chronic elevation, we're looking for a rise of at least 20% from baseline. And in patients with normal baseline troponin, a rise above the 99th percentile and a relative increase of 50 to 60% from their baseline is diagnostic. The emphasis on the dynamic change helps to distinguish a chronic elevation from the from new myocardial injury that needs attention. Now, while an in-depth discussion into the management of a postoperative MI is a little bit beyond the scope of this talk, I do want to briefly discuss what an initial evaluation may look like if we begin checking troponins more routinely. So when evaluating a troponin level postoperatively, the first step is to determine whether it meets the criteria of a significant elevation. Is it greater than the 99th percentile? Or in a patient who has chronically elevated levels, is it an increase of at least 20% from their baseline? If so, then a 12-lead ECG, a bedside assessment of symptoms, and potentially a focused cardiac ultrasound again to quickly evaluate for wall motion abnormalities or other signs of acute cardiac dysfunction is warranted. The immediate goal is to rule out a STEMI. Once a STEMI is ruled out, assess whether the situation meets any of the other criteria for MI, which are displayed here on the screen. If the criteria for MI are met, management should proceed as with any NSTEMI, with a focus on determining the likelihood of plaque rupture, and then carefully weighing the risks and benefits of angiography, antiplatelets, or anticoagulation in the post-op setting. But if criteria for MI are not met, these patients get categorized as MINS, and this is where the path forward becomes much less clear. We know MINS is important because of its association with poor outcomes, but no studies to date have demonstrated that specific interventions improve outcomes in that group. Because of this, the guidelines recommend that we at least acknowledge the diagnosis and ensure appropriate outpatient follow-up to discuss longer-term risk modification strategies. In summary, I hope you leave with a better understanding of what biomarker-enhanced risk stratification can look like in the perioperative setting. We've discussed how to deploy these biomarkers thoughtfully in your practice as tools to identify risk as well as subclinical ischemia, while recognizing that our evidence-based guidance on action is still evolving. For now, we can use these tools to risk stratify, communicate with each other, and follow up on our at-risk patients. Thank you.
All right. Okay. Good afternoon, everyone. Now for the last part of this here. So my name is Alok Gupta. I'm an associate professor at Northwestern in Chicago, and I'll be talking about elevated INRs. So, you have a patient coming in for elective surgery or semi-elective surgery or even urgent surgery. What do you do? Not advancing. There we go. I don't have any financial disclosures, but I do like silly memes, so please excuse those. So, this is a typical case here. So, a 60-year-old male who has a right hip fracture coming in. If your patients are anything like my patients, they have hypertension, OSA, they've got NASH cirrhosis, on 2 liters of oxygen at home with COPD, and has some dyspnea as well, possible pain from their hip fracture. They're also obese with a large neck circumference. So, the question becomes, what do you do with this patient? And by the way, their preoperative labs show, they're moderately thrombocytopenic, but they've also got a mildly elevated INR of 1.5. So, as our favorite cascade here with the coagulation cascade, the INR is prolonged when your factor 7 activity is usually reduced to somewhere around 55% of your baseline. An INR of 1.5 is associated with a factor 7 activity of about 40%. An INR less than 1.5 is usually associated with normal coagulation. And so that's, as we'll see, that's why some of the guidelines are based at around an INR of 1.4. So patients who have an INR of less than or equal to 1.4 should really not be at any risk of any sort of spinal bleeding. When we look at new guidelines here from the ASA, looking at the care of older adults for scheduled patients, the question always becomes, should we do a regional, or should we do a neuraxial technique, or should we do a general technique? And basically, either. It's really up to you what you want to do, and it's shared decision-making between you and the patient, looking at the patient's comorbidities and seeing which one might be better in that situation. This is actually where we may agree with some of our surgical colleagues. The American Academy of Orthopedic Surgeons says basically the same thing. For, hip fracture in older patients, either a spinal or a general is appropriate in these patients. However, there is some data, looking at these patients in general. So this study is about 10 years old, 10, 15 years old, looking at patients with COPD specifically who are receiving either regional or general anesthesia. And there was an increased risk of postoperative pulmonary complications in these patients. But what does some of our newer data show? So this is from 2021, and this was a randomized multicenter trial of about 1,600 patients older than 50. And they showed there was really no difference in outcomes between spinal and general anesthesia for a hip fracture in these patients. One of the problems, one of the criticisms of this study is that they defined older as greater than 50 and as someone who is approaching that age. I disagree with them wholeheartedly. The spinal group also received intraoperative sedation, which, they suspect may have mitigated some of the benefits of spinal anesthesia as compared to general anesthetic in this study. So, the question becomes, which one are we really going to choose? Are we going to go spinal or are we going to go general? There has been a newer study here. This was a systematic review and meta-analysis of about 21 different studies. And here the mean age was greater than 65. So probably a little bit more likely and closer to our patient in this case. And what they showed is that there actually was an increased risk of, or there was favorability of regional anesthesia when it came to post-op complications, mortality, as well as readmission and reoperation rates in these patients. So, again, looking at, kind of older, sicker patients, there may be a benefit to regional anesthesia. This is from the Association of Anesthetists. I just like saying anesthetists. And, they say that there's really not a lot of difference between general and regional anesthesia. And as with any vague guidelines, it's really about the careful delivery of anesthesia that may be of greater importance versus the type of anesthesia that's delivered. That's like a cardiology consult saying to avoid hypotension intraoperatively. I think the key point here is kind of that last part there is that for some patients taking anticoagulant or antiplatelet medications, the risk of vertebral canal hematoma may be very considerably less than the risk of general anesthesia. So you really have to balance that, looking at your patient and their comorbidities and the risk of general anesthesia. So they go on to say, in their guidelines here that, proceed with neuraxial anesthesia if the INR is less than or equal to 1.5 is kind of their cutoff, and we'll review what ASRA says here as well. As you remember, this patient has NASH cirrhosis, right? So they're not somebody who's on, a vitamin K antagonist. They have some sort of intrinsic disease. So what do we know about bleeding in patients who have cirrhosis? So, when you look at the blue line there, so, these patients are the cirrhotic patients, and this was looking at about 80,000 patients, 14,000 of them with chronic liver disease. An elevated INR is absolutely associated with an increased risk of hemorrhage, but as that INR increased, that risk really kind of stayed the same as when you compare to patients, who are on those vitamin K antagonists. That risk of hemorrhage does increase exponentially in those patients. So yes, there's a risk of bleeding, but that risk of bleeding is fairly stable as that INR increases. When we look at other guidelines here, so when we look at ASRA and the European Society of Anesthesiology, so patients not receiving warfarin, they recommend an INR of less than or equal to 1.4. So if you remember, we're right at 1.5, so we're just above that level or that recommendation. And ASRA makes a distinction that patients who are receiving vitamin K analogs, it really should be less than or equal to 1.2 versus that 1.4. But what do other societies say? So we're not the only ones who perform, spinals or lumbar punctures, right? So what does neurology say? So neurology says, INR less than 1.5. So again, that's less than or equal to 1.4. We love using less than or equal to differently here. So that's what our neurology colleagues will say. But what about our Society of Interventional Radiology? So they actually look at their procedures based on low risk of bleeding or high risk of bleeding procedures. And they put lumbar puncture in that low risk category. And they say that there's no need to routinely check a PTR and INR in patients before doing a lumbar puncture. If you happen to check it, maybe correct it between 2 and 3 before doing it. But again, they're using fluoroscopy, whereas we tend to be doing them blind. So there could be a little bit different in technique in that situation. So again, here, they're saying an INR less than 2.5 is totally fine for doing a high-risk procedure, whereas they classify lumbar puncture as a low-risk procedure. What about, the abnormal coagulation in the cirrhotic patients, so our patients here. So this is from the International Society of Thrombosis and Hemostasis. And, they're really pointing out that this elevated INR in our cirrhotic patients is from a rebalanced hemostasis. So it's not purely, that these patients could be bleeding. And their guidance in terms of, doing these procedures, they don't address lumbar puncture specifically, but I kind of use cranial or spinal surgery, which we all know is a little bit more invasive than our spinals, is high bleeding risk. And, they also say don't, evaluate it correctly, don't, routinely evaluate it. And if we look at all these other societies, so the American Association for the Study of Liver Diseases, the American Gastroenterology Association, American College of Gastroenterology, they all say don't correct an elevated INR in these cirrhotic patients before surgery. So don't use that INR to predict a patient's bleeding risk. If we look at the association of lumbar puncture with a spinal hematoma in patients who do and don't have coagulopathy, this was a retrospective study looking at 30-day risk of spinal hematoma in patients. This is over 80,000 lumbar punctures and in about 65,000 patients. So some patients had multiple lumbar punctures over this. The risk of spinal hematoma was 0.2% in patients with no coagulopathy and 0.23% in patients who did have coagulopathy. And they defined coagulopathy as platelets less than 150, an INR greater than 1.4, and a PTT greater than 39 seconds. Of note here, there were no spinal hematomas among patients with a high INR, which they defined above 1.5. So some patients even had them with INRs of 4 with first-time lumbar puncture. There's one that you note there between 1.5 and 2.0. That was a repeat lumbar puncture. So of first lumbar punctures, there were no spinal hematomas in patients with elevated INRs. What about the use of point-of-care testing for this? So this was actually from a case report of a patient, of a gravid patient coming for C-section who had congenital factor VII deficiency. So their factor VII level, they didn't report the INR in this patient, but the factor VII level was measured at 30%. So as you remember previously, an INR of 1.5 is about 40% activity in these patients. So they did a ROTEM or a NATEM or a non-activated thromboelastometry in this patient, which was completely normal in this patient here. Patient also had a history of hepatectomy in the past. All parameters were in reference range. They did the spinal, and patient was fine in this situation. Going back to the American Gastroenterology Association here, global tests of clot formation such as rotational thromboelastometry, thromboelastography may eventually have a role, but we have no defined parameters right now. So there is a role for it, but we just don't have guidelines to base this. So, going back to what do we do here? So what are we going to do? Are we going to do a spinal? Are we going to do a general for this patient? So I really did what any good anesthesiologist would do these days, is I asked ChatGPT. Right? And so, ChatGPT comes out to be pretty conservative in terms of what they're going to do. They say if the INR is borderline, consider a spinal, really look at that patient, look at their pulmonary risk. Is that risk of general greater than that risk, that 0.2% risk of a spinal hematoma? And just going back to the ASRA guidelines, it's not, the word of God, right? It said, they specifically say there that the recommendations do not define the standard of care. It's not intended to replace clinical judgment, and compliance with the recommendations may not result in an improved outcome, and we really should be personalizing our choice for these patients. Thank you, and I think we'll open it up for questions.
It's 5 o'clock somewhere. That somewhere is here. If anyone has questions for the speakers, please come up. They'd be happy to take those, and happy Saturday.